I have seen people come into the emergency room in genuine tears, not from a broken bone, not from chest pain, but because they have not had a bowel movement in 8, 9, sometimes 12 days, and the pain from what is sitting trapped inside them has become so severe they cannot sit, cannot lie down, cannot find a single position that brings relief. One patient told me she had tried everything: laxatives, enemas, even physically attempting to manually clear the blockage herself out of sheer desperation, and nothing worked. And by the time she reached me, the situation had progressed to something requiring direct medical intervention that could have been completely avoided with one simple kitchen ingredient used correctly, days earlier, before things ever reached that point. I am telling you this not to frighten you, but because I want you to understand exactly how serious this situation can become if it is mismanaged or ignored, and exactly what the 1 teaspoon solution is that resolves the vast majority of these cases within minutes when used properly, long before anyone needs to end up where that patient did. Stay through this entire video because the specific warning signs I cover near the end are exactly what separates a problem you can solve safely at home from one that requires you to put down whatever you are doing and seek medical care immediately. Let me start by explaining exactly what is happening physically when stool becomes stuck in the rectum, because understanding the mechanism makes the solution make complete sense rather than feeling like a random trick you stumbled across online. The rectum is the final several inches of your large intestine, immediately before the anus, and its job is to hold stool temporarily until you have the opportunity and the urge to have a bowel movement. Under normal circumstances, stool arrives in the rectum already softened by water absorbed throughout its journey through the colon, and the rectal walls stretch to accommodate it, triggering nerve signals that create the urge to go. The problem develops when stool sits in the rectum for too long before being passed, because the rectum, like the rest of the colon, continues absorbing water from its contents the entire time stool remains inside it. The longer stool sits there, whether because of dehydration, certain medications, reduced physical activity, or simply ignoring the urge to go at the moment it first appears, the more water gets pulled out of it, and the harder, drier, and more compacted it becomes. Eventually, this compacted mass becomes too large, too hard, or too irregularly shaped to pass through the anal canal using normal pushing effort alone, creating exactly the sensation of something solid and immovable, blocking the way no matter how hard you strain. This is medically referred to as fecal impaction when it becomes severe, and the patient I mentioned at the beginning of this video had reached the far end of that spectrum, a point that almost always could have been avoided entirely with earlier, simple intervention. Now let me give you the 1 teaspoon solution, because I know that is what brought you to this video. And I want to be completely specific about both what it is and exactly how to use it correctly, since using it incorrectly significantly reduces how well it works. The solution is 1 teaspoon of mineral oil, taken orally, though I want to immediately clarify an important distinction that most people watching videos like this one never hear explained properly. Mineral oil works through a mechanism called lubrication, meaning it coats the surface of the stool and the lining of the intestine, allowing the hardened mass to slide through the rectum and anal canal with dramatically less friction than it would otherwise encounter, even without making the stool itself any softer in composition. This is fundamentally different from how fiber or stool softeners work, which act by drawing water into the stool to soften it from within, a process that takes considerably longer, sometimes a full day or more, to produce a noticeable effect. Mineral oil's lubricating effect, by contrast, can begin working within as little as 30 minutes to a few hours when taken orally, because it does not need to be absorbed or metabolized to produce its effect. It simply needs to physically reach and coat the stool as it travels through your digestive system. For an existing blockage that is already sitting in the rectum, an oral dose can help, but for stool that is already firmly impacted right at the point of exit, many people find that mineral oil works even faster and more directly when used as a small enema, where the oil is introduced directly into the rectum itself rather than swallowed and having to travel the entire length of the digestive tract first. Prepackaged mineral oil enemas are widely available without a prescription at most pharmacies, and they work by delivering that same lubricating effect directly to the site of the blockage, often producing results within just minutes rather than the hour or more that oral mineral oil typically requires to reach the rectum from the stomach. I want to address something important about safety and proper use here, because while mineral oil is generally very safe for occasional use, there are specific situations where it should be avoided or used only under direct medical guidance. Mineral oil should never be taken at the same time as certain other medications, particularly some blood thinners, since it can interfere with how well your body absorbs certain nutrients and medications if used regularly or in large amounts, which is exactly why it is appropriate for occasional, specific use during an episode like the one we are discussing, rather than as a regular daily habit for ongoing constipation management. It should also be used cautiously, ideally only under medical guidance, in anyone with swallowing difficulties, since there is a rare but serious risk of accidentally inhaling small amounts of oil into the lungs if it is swallowed improperly, a complication called lipoid pneumonia that, while uncommon, is serious enough to mention clearly. For most healthy adults, using a single teaspoon dose occasionally to address an acute episode of difficulty passing stool, this risk is minimal. But if you have any difficulty swallowing liquids generally, or any condition affecting your swallowing reflex, this is a situation where speaking with a pharmacist or physician before using mineral oil orally is the safer approach, with the enema delivery method being a reasonable alternative that avoids the swallowing concern entirely since it bypasses the mouth and throat completely. I also want to mention a complementary approach that works alongside mineral oil and that many people find helpful specifically for the mechanical aspect of passing an already formed stuck stool, which is positioning. The angle at which you sit during a bowel movement actually has a measurable effect on how easily stool passes because of a muscle called the puborectalis that wraps around the rectum and creates a natural kink in its pathway when you are sitting in a typical upright position on a standard toilet. This kink exists for a practical reason most of the time, helping maintain continence when you are not actively trying to have a bowel movement, but it works against you specifically when you are trying to pass something that is already difficult to move. Placing your feet on a small stool 6 to 8 inches high, positioned in front of the toilet so that your knees rise above your hip level, mimics a squatting position that straightens this natural kink, allowing for a much more direct, unobstructed pathway. This single change in position, combined with the lubricating effect of mineral oil, addresses both the chemical and the mechanical aspects of why stool gets stuck. And I have had patients tell me they were genuinely surprised by how much easier passage became simply from this positioning change alone, even before considering any other intervention. Let me talk about why this happens in the first place, because addressing the underlying causes matters just as much as resolving an acute episode, particularly if this is a recurring problem for you rather than an isolated incident. Dehydration is one of the most common and most easily correctable underlying causes, since adequate water intake is essential for keeping stool soft enough to pass without difficulty, and many older adults are mildly, chronically dehydrated without realizing it, since the sensation of thirst naturally diminishes with age, meaning you can be meaningfully dehydrated without feeling particularly thirsty as a warning signal. Certain medications are also significant contributors, particularly opioid pain medications, which directly slow intestinal movement as part of their mechanism of action. Certain blood pressure medications, particularly calcium channel blockers like amlodipine, which can slow intestinal motility as a side effect of the same mechanism that relaxes blood vessels, and iron supplements, which are notorious for causing constipation in a significant percentage of people who take them regularly. Reduced physical activity plays a meaningful role as well, since movement of your body, particularly walking, directly stimulates the natural, wave-like muscular contractions of the colon, called peristalsis, that move stool along its path, which means a more sedentary lifestyle, whether from reduced mobility, illness, or simply changes in daily routine, can meaningfully slow this process. Ignoring the urge to have a bowel movement when it first appears, often because of being in a public place, being busy with another activity, or simply finding the timing inconvenient, also contributes significantly over time, since repeatedly suppressing this urge can gradually reduce the rectum's sensitivity to the signal of stool being present, requiring a larger and larger volume before the urge becomes strong enough to act on, which itself contributes to the kind of prolonged retention that leads to impaction. I want to talk specifically about fiber, because there is a common misconception that simply increasing fiber intake is always the right answer for any kind of constipation, when in reality, the relationship is more nuanced and depends on the specific situation. Fiber works by adding bulk to stool and, in the case of soluble fiber specifically, by drawing water into the stool to help soften it, which is genuinely helpful for preventing constipation when taken consistently as part of a regular diet with adequate water intake alongside it. However, if someone already has stool firmly impacted in the rectum, and they suddenly increase fiber intake significantly without simultaneously ensuring very high water intake, The added bulk from fiber without adequate accompanying fluid can actually worsen the immediate blockage rather than helping it, since fiber needs water to do its softening work properly, and adding bulk without adequate fluid simply adds more material to an already difficult situation. This is exactly why, during an acute episode like the one this patient I described experienced, the priority is addressing the immediate blockage first, through lubrication and proper positioning, with attention to fiber and hydration becoming the focus afterward once the acute episode has resolved, as part of a longer-term strategy to prevent recurrence, rather than as the immediate solution to a stool that is already stuck and causing significant discomfort right now. Now, I want to walk through the warning signs that I mentioned at the beginning, because this is genuinely the most important part of this entire video. And this is exactly the line that separated my patient's situation from one she could have resolved safely on her own. Severe abdominal pain that is sharp, constant, and significantly worse than ordinary straining discomfort, particularly if it is accompanied by abdominal swelling or a visibly distended belly, can indicate a bowel obstruction that requires emergency medical attention, since attempting to push through this kind of blockage can in rare cases lead to serious complications, including a tear in the bowel wall. Vomiting, particularly if it becomes persistent or if you notice that what you are vomiting looks like stool or has a distinctly fecal odor, is an emergency warning sign that should prompt immediate medical attention, since this can indicate a complete obstruction where the bowel's contents are essentially backing up because nothing can move forward past the blockage point. Rectal bleeding that is significant, meaning more than a small amount of bright red blood on the toilet paper that sometimes occurs from minor irritation during straining, particularly if the blood is dark or mixed throughout the stool rather than simply on the surface, deserves prompt medical evaluation rather than continued attempts at home management. Fever accompanying any of these symptoms suggests a possible infection or inflammation that requires medical evaluation rather than home treatment. And finally, if you have tried the approaches discussed in this video, the mineral oil, the positioning, adequate time and patience, and you are still completely unable to pass any stool after several days, this represents a situation that has moved beyond what home remedies can appropriately address and requires direct medical evaluation. Since a healthcare provider may need to perform a manual disimpaction or use other medical interventions that are simply not appropriate or safe to attempt without proper training and equipment, which is exactly the point my earlier patient eventually reached, days later than necessary, after attempting to manage it entirely on her own, well past the point where home approaches were still appropriate. I also want to address something that often goes unspoken because it can feel embarrassing to discuss, even with a doctor, which is that fecal impaction and significant constipation are genuinely common reasons for emergency department visits and urgent care appointments, particularly among older adults, and there is absolutely no reason to feel embarrassed about seeking medical attention for this if home approaches are not working or if any of the warning signs I just described are present. I see this situation regularly in my own practice, and a manual disimpaction, while certainly not anyone's preferred way to spend a medical appointment, is a routine, straightforward procedure that brings significant relief very quickly once completed. Delaying care out of embarrassment, exactly what happened with the patient I described earlier, only risks the situation progressing to something more serious and potentially more dangerous, including the rare but real possibility of a bowel obstruction requiring more invasive intervention than would have been necessary with earlier evaluation. I want to spend a moment on prevention, because once an acute episode resolves, the goal becomes avoiding a repeat occurrence, and several specific manageable habits make a meaningful difference over time. Maintaining consistent, adequate water intake throughout the day, generally 50 to 64 ounces for most adults unless your physician has given you a specific different target for other health reasons, keeps stool naturally softer and easier to pass without needing to rely on interventions during an acute episode. Gradually increasing fiber intake through whole foods like vegetables, fruits, and legumes should be done gradually over several weeks rather than all at once, since a sudden large increase in fiber can itself cause temporary bloating and discomfort, particularly if water intake does not increase proportionally alongside it. Regular physical activity, even a daily walk of 20 to 30 minutes, provides meaningful stimulation to normal intestinal movement and is one of the most consistently effective, low-cost interventions for preventing constipation in people whose activity level has decreased for any reason. Responding promptly to the natural urge to have a bowel movement when it first appears, rather than habitually delaying or suppressing it, helps maintain the rectum's normal sensitivity to this signal over time, preventing the gradual desensitization that can develop from repeated suppression. And if you are taking any medication known to commonly cause constipation as a side effect, particularly opioid pain medications, certain blood pressure medications, or iron supplements, discussing this specific side effect with your prescribing physician is worthwhile, since in some cases an alternative medication with less impact on bowel function may be available, or a preventive approach using a stool softener alongside the medication from the start may be appropriate rather than waiting for constipation to become a significant problem before addressing it. I think it is worth explaining specifically why this entire situation becomes so much more common as we age, beyond the individual risk factors I already mentioned, because understanding the bigger picture helps explain why I see this so often, specifically among older patients in my own practice. The muscles involved in moving stool through the colon, the same peristaltic contractions I mentioned earlier, naturally weaken somewhat with age, similar to how other muscles throughout the body lose some strength and efficiency over time without active effort to maintain them. The nerve signals that coordinate this muscular movement and that create the sensation of needing to have a bowel movement also become somewhat less sensitive with age in many people, meaning the urge itself may arrive later or feel less distinct than it once did, which can lead to stool sitting longer before the urge becomes strong enough to prompt action. Additionally, older adults are simply more likely to be taking one or more of the constipating medications we discussed, whether for blood pressure, pain management, or other chronic conditions, and are statistically more likely to have reduced mobility compared to younger adults, whether from joint issues, balance concerns, or general activity level changes that come with different life circumstances. None of this means difficulty with bowel movements is an inevitable, unavoidable part of aging that simply must be accepted. It means understanding that multiple factors tend to compound together as we age, which is exactly why a proactive, comprehensive approach addressing hydration, activity, diet, and medication review together tends to work far better than addressing any single factor in isolation, and far better than waiting until a situation becomes as severe as the one I described at the start of this video. I want to go into a bit more specific detail about which dietary sources of fiber tend to work particularly well for supporting regular, comfortable bowel movements, since not all fiber behaves identically, and some specific choices tend to be more effective and better tolerated than others, particularly for people who have struggled with constipation previously. Prunes, and prune juice specifically, have long been recognized as particularly effective, and this is not simply folk wisdom, since research has confirmed that prunes contain both a meaningful amount of fiber and a natural compound called sorbitol, a sugar alcohol that draws water into the intestine through an osmotic effect, essentially pulling fluid into the colon to help soften stool through a mechanism similar to how certain over-the-counter laxatives work, except through a naturally occurring food source rather than a manufactured product. A serving of 4 to 5 prunes daily, or a small glass of prune juice, represents a genuinely well-studied, effective addition for many people dealing with mild to moderate constipation concerns. Ground flaxseed, added to oatmeal, yogurt, or smoothies, provides both soluble fiber that softens stool and a small amount of healthy fat that some research suggests may have a mild additional lubricating effect on stool passage. Chia seeds work somewhat similarly, forming a gel-like substance when mixed with liquid that adds both bulk and moisture retention to stool as it moves through the digestive system, and many patients find them easy to incorporate simply by adding a tablespoon to water, juice, or oatmeal each morning, letting them sit for a few minutes to develop their characteristic gel-like texture before consuming. Pears and apples, eaten with the skin intact rather than peeled, contain a specific type of soluble fiber called pectin that is particularly concentrated in the skin itself, which is part of why I generally recommend eating these fruits whole rather than peeled when digestive regularity is a specific concern. Kiwi fruit, somewhat less commonly mentioned but increasingly supported by research specifically focused on digestive health, contains both fiber and a digestive enzyme called actinidin that appears to support more comfortable, regular bowel movements when eaten consistently, typically 2 kiwis daily, over several weeks. The common thread across all of these specific foods is that they work best when introduced consistently as part of a regular dietary pattern, alongside adequate water intake to support their function, rather than being used as a one-time intervention during an already established acute episode of impaction, which is exactly why the immediate solution for an acute episode remains the mineral oil and positioning approach we discussed earlier, with these dietary additions serving the complementary, longer-term role of reducing how often acute episodes occur in the first place, and ideally preventing anyone from ever ending up in the kind of situation my patient described at the beginning of this video found herself in. I also want to mention a few complementary approaches that some people find helpful alongside mineral oil, since understanding why each one works helps you choose the combination that makes the most sense for your specific situation. Warm water itself, whether as a warm beverage taken internally or as a warm compress applied gently to the lower abdomen, can help relax the abdominal muscles and reduce the involuntary tension that sometimes accompanies the discomfort of an impaction, making the eventual passage somewhat easier once the mineral oil has had time to take effect. Gentle abdominal massage, performed in a clockwise direction following the natural path of the colon, starting from the lower right side of the abdomen, moving up, across, and down to the lower left side, can help stimulate movement of stool through the colon toward the rectum. Though this technique works best as a preventive measure used regularly rather than as an immediate solution for stool that is already firmly impacted right at the point of exit. Glycerin suppositories, available without a prescription at most pharmacies, work through a similar lubricating mechanism to mineral oil, but are inserted directly and tend to act somewhat faster for stool that is positioned very close to the anal opening specifically, making them a reasonable alternative or complement to mineral oil, depending on exactly where the blockage seems to be located, based on your own sensation of where the difficulty is occurring. I also want to briefly address something that sometimes gets confused with simple constipation, but that represents a meaningfully different and more serious underlying issue, which is when difficulty passing stool occurs alongside other symptoms that suggest something beyond ordinary dietary or medication-related constipation. A sudden, significant change in bowel habits that persists for several weeks, particularly alternating between difficulty passing stool and unusually loose stool, especially in someone over 50 without an obvious explanation like a new medication or illness, deserves a more thorough medical evaluation, since this particular pattern can occasionally indicate other conditions affecting the colon that require specific diagnostic attention beyond what home remedies for occasional constipation are designed to address. This does not mean every episode of difficulty passing stool warrants this level of concern, since occasional constipation related to dehydration, reduced activity, or medication side effects, exactly the kind of situation we have focused on throughout this video, is overwhelmingly the most common explanation and resolves well with the approaches we have discussed. But a persistent, unexplained change in your normal bowel pattern that continues for several weeks, rather than resolving as an isolated episode, is worth mentioning specifically to your physician as a distinct concern from a single acute episode of constipation, like the one this video primarily addresses. And it is exactly the kind of distinction I make with every patient who comes to me describing their bowel habits, since the conversation and the recommended approach genuinely differ depending on whether we are addressing an isolated, explainable episode or a persistent, unexplained pattern. I want to bring this together with a clear, practical summary you can actually use. If you are currently experiencing this exact situation, stool that feels stuck and will not pass despite significant straining effort, and you do not have any of the emergency warning signs I described, a reasonable first approach is 1 teaspoon of mineral oil, either taken orally if you do not have swallowing difficulties, or used as a rectal enema if you want faster, more direct results, combined with proper positioning using a small footstool to elevate your knees above hip level while sitting on the toilet. Give this combination adequate time to work, generally 30 minutes to a few hours depending on the method used, while staying alert to any of the warning signs we discussed. If those warning signs appear, or if several days pass without any improvement despite these efforts, this has moved beyond what home treatment can appropriately address, and direct medical evaluation is the safe, appropriate next step, without any reason for embarrassment or hesitation in seeking that care, and without waiting as long as the patient I described at the beginning of this video unfortunately did. If this video helped you understand something about your own situation more clearly, or if you have a specific question about digestive health that you would like me to address in a future video, leave it in the comments below because I read every single one, and these specific questions often shape exactly what we cover next. Take care of yourself, and I will see you in the next one.